Hi, it's an honor to be speaking now at the third HnR conference, and I'm going to give a very brief overview of ventilator-induced lung injury and patient self-inflicted lung injury. These are my conflicts. I am a co-founder of an ultrasound startup in Toronto. Some news: my physiology book will be coming out shortly, probably within the next month or so. I'll announce it on Twitter, and it will be free and open access. So to start with volumetrauma or barotrauma, and this was a topic that I found confusing early in my training, and I wasn't really entirely sure whether we should be focusing on the volume or the pressure in ARDS, because it seemed like we were targeting both. Was one more important than the other? Turns out, as I hope to show you, that they're essentially the same thing. We just might not have been looking at it in the correct way. So in a lot of Gatnoni's physiology works, you may read that in severe ARDS, the lung is small, not stiff, which I found also confusing because it seemed contrary to everything that I had been taught and what I was seeing in the bedside. It seemed like in severe ARDS, the lungs were quite stiff. If you gave the same tidal volume as compared to normal lungs, the pressure was much higher. So how do we square these facets? And in order to think of the lung being small rather than stiff in a material science perspective, you have to think of the lung in terms of its strain versus its stress. So here I've depicted strain on the y-axis, and that will be analogous to the volume of the lungs. And on the x-axis, I've depicted the stress or the pressure, and here the TP is the transpulmonary pressure, so it's the pressure in the airway or in the alveolus relative to the pleural pressure, not the atmospheric pressure. Remember on the ventilator, if you're doing say an inspiratory hold to measure the plateau pressure without an esophageal balloon, what you're measuring is the transrespiratory pressure. You're not actually measuring the transpulmonary pressure. So then the question might be, well, what is strain? So strain is the tidal volume, that's in the numerator, divided by what I'm going to say is the functional residual capacity of the lung. So it's not just the amount of volume that you're delivering to the lung, but it's the amount of volume that you're delivering to the lung relative to the capacitance of the lung. And that's really the key, because the size of the aerated lung in severe ARDS, the denominator, the FRC, can actually get quite small. So in a normal lung, if you were to plot the stress on the x-axis across the lung versus the strain on the y-axis here, you get a pretty linear relationship up to a strain of 2.5-ish, and then it kind of becomes curvilinear. But for here, it's normal. What's interesting, if you do the same experiment for severe ARDS, the slope is essentially right on top of each other. So the relationship between stress and strain is mediated by this slope, and it's called K, or the specific elastance. And in humans, it's about 12 centimeters of water. In pigs, it's about half that. Nevertheless, you know that if you increase the strain of the lungs to a value of 1, that you generate a pressure across the lungs of 12 centimeters of water. You can think of it the other way around too. If you deliver 12 centimeters of water across the lung, then you have strained it by 1. And it's the same whether it's normal or severe ARDS. So that might be a bit abstract. So give me a little bit more of a concrete clinical example. So let's say this is more severe ARDS with a small baby lung, that the container into which you can push volume in this lung is only 200 cc's. And in this lung, it's, let's say, double that, it's 400 cc's. So if you're to deliver a tidal volume on the ventilator, let's assume the patient is passive in volume control, you deliver 400 cc's breath to the bottom patient. You can see here that the strain is 1 because you're delivering 400 cc's into a lung that can accept 400 cc's, let's say. Conversely, in the other patient, the more severe disease, obviously the strain is 2 because you're applying twice the volume that the lung can accept. And so it's the same tidal volume, it's dialed into the ventilator, but actually the effect on the lung is quite different. You're doubling the strain in the top patient compared to the bottom patient. And then what that causes is a stress. And the stress is the pressure in, let's say, the alveolus relative to the pleural pressure. And you can see, even though the tidal volume is the same between these two patients, the stress in the top lung is, surprise, surprise, twice as great as the stress in the bottom lung. So let's go back to this graph. So we're going to say the strain is 400 cc's. In the less severe disease, it generates only a strain of 1, and therefore the transpulmonary stress is 12 centimeters of water. Whereas deliver the same tidal volume to a more severe case, you've doubled the strain, and now the transpulmonary stress is 24 centimeters of water. What's the value that's injurious in human lungs? It's not entirely known. In porcine lungs, the strain of about 1.5 and above consistently delivered tends to result in villi. So in humans, certainly above 1.5, 2.0 strain, you're going to be generating transpulmonary stresses well above 20 centimeters of water, which over time will will likely become injurious. The problem is, as you may have guessed, is you never really know the size of the baby lung. So the volume that you're delivering, you don't really know what strain you're generating. All you know is that the smaller the volume you deliver, the safer it should be. So based on that linear relationship on the graph, you can develop this equation. Stress is the elastance times the strain. So now this can be made a little bit more clinically relevant if you think of the stress on the left as barotrauma, injurious stress, and on the right, the strain is injurious volume or volumetrauma. So the important thing is, when you're thinking about the stress or the pressure, as I've already mentioned, it's not just the airway pressure is key, it's the airway pressure relative to the pleural pressure, and you're typically ignorant of this. Similarly, for the volumetrauma or the strain, you know this, but you're typically ignorant of this. And so when you're thinking of barotrauma and volumetrauma, if you think of this equation, you can see that volumetrauma is barotrauma, barotrauma is volumetrauma. They are mathematically on par, but they're on par only when you're looking at them from a material science perspective. That is the strain relative to the stress, and the strain is the volume relative to the baseline volume, and the stress is the pressure relative to the outside pressure. So typically you know this, you don't know this, typically you know this, and you don't know this. So if you're just thinking in terms of the volume dialed in, or just thinking in terms of the airway pressure, you can see how it can become problematic comparing the two. But when you have all of the information, volumetrauma and barotrauma are the same thing. So how does that relate to atelect trauma? Well, I think atelect trauma is really nicely explained by the stress razor hypothesis, and that's just a broadening or a natural progression of stress and strain that we just talked about. So what's a stress razor? So this is a homogeneous lung unit of 7 hexagons to which you apply, say, a strain, a passive patient, and that strain is distributed homogeneously to all of these units, and you develop a known stress. So if you increase the strain by 1 in the human lungs, the stress that occurs across these hexagons would be 12 centimeters of water. Problem is that the lungs aren't perfectly homogeneous, so there's always stress razors in the lung, and a stress razor is 2 areas of adjacent material that are not homogeneous, inhomogeneous with respect to their elasticity. And what the stress razor does is it augments the radial traction forces around the area of the stress razor, and so it amplifies that stress. You can sort of think of it as increasing the specific elastance, so to say. So instead of 12 centimeters, maybe it's 24, or maybe it's even greater. So when you apply the strain, it's not homogeneously distributed, so you augment the stress. So there's this classic model from the 1970s by Mead and colleagues. It's often referenced, and what they found is that the amplification factor here is 4.6. So instead of a strain of 1 leading to a stress of 12, a strain of 1 would result in a stress of over 50 centimeters of water. Clinically, I think Gattinoni's group found it to be closer to a stress amplification of 2. So instead of 12 centimeters per every 1 of strain, you're getting 24 centimeters per every 1 of strain. Nevertheless, it's this idea that when there's inhomogeneities within the lung, the stress is amplified. And all lungs have stress razors at baseline: an airway next to the parenchyma, a blood vessel next to the parenchyma, the visceral pleura next to the parietal pleura, the visceral pleural next to the parenchyma. These are all areas of differing elasticity, so all lungs have some degree of stress razors. Just the more severe ARDS has a greater burden of stress razors. So this slide is just to show you that the stress razor hypothesis applies not just to alveoli having their transmural stress augmented, but blood vessels do too, particularly these corner vessels, which Marina writes about in a nice review from the early 2000s. But in this situation, you can very easily get transcapillary pressures. If you use the Mead model augmentation index, you can very easily get transcapillary pressures approaching 100 millimeters of mercury. So this stress razor hypothesis can fracture capillaries as well, which leads to edema and villi and more stress razors, and it can become a self-fulfilling cycle. So that leads to this, I think, this idea of patient self-inflicted lung injury. And so what we've talked about so far is essentially a passive patient, let's say in volume control, receiving a strain to a stress razor in ARDS, and you have this augmentation of radial traction stress that can increase essentially volumetrauma and barotrauma. But what happens if this stress is not the output as a result of simply the strain multiplied by the specific elastance multiplied by the amplification from the stress razor? What if there's something else that's contributing to the stress, namely patient effort? So not only is the pressure augmented because of the strain that's delivered, but if the patient is lowering the pressure around the stress razor, then you're amplifying the stress. And this is kind of the foundation of P-SILI. And what's been found in a number of really elegant works, particularly by Dr. Yoshida's group, is that you develop Pandaluftas. So Pandaluftas means swinging of air in German. And that occurs because the lung grossly can sort of act as one giant stress raiser. So in the normal lung, we'll call the normal lung as behaving as fluid-like. When you lower the pleural pressure, this fluid-like behavior of the lung allows for the pleural pressure to homogeneously decrease around the surface of the lung. That's normal. In bad ARDS, where you have solid-like or brick-like behavior of consolidated lung, this is kind of like one big stress raiser. And they've shown pretty convincingly that when the diaphragm contracts in this situation, you have inhomogeneity of the pleural pressure gradient. So instead of diffusely lowering around the lung, you actually have this amplification of the fall in the pleural pressure in the dependent caudal regions of the lung relative to the non-dependent ventral regions of the lung. And so this actually amplifies local stress down in the dependent portions of the lung. So that's this difference between fluid-like and solid-like lung. And the decrease in pressure in the dependent area relative to the non-dependent area has actually been shown to suck air down from the dependent regions of the lung, which increases the strain. So you're increasing the stress by lowering pleural pressure by diaphragmatic contraction, and then volume is sucked down from the non-dependent regions, augmenting the strain. So this P-SILI is perpetuated by this Pandaluftas effect, and it shouldn't escape the viewer that something similar can happen with blood as well. As I showed in the blood vessels, if you're increasing the radial traction forces on blood vessels, you could get something called Pandalblut, or swinging of blood to the areas of increased stress. So you can see, based on this pathophysiology, that P-SILI is probably mediated by three things converging. So there's excessive dependent stress raisers in the lung. So that's the solid-like behavior where you are inhomogeneous in a non-homogeneous fashion. You are augmenting pleural pressure stress in the dependent lung, coupled with excessive effort, low pleural pressure, and in particular low positive end expiratory pressure, because positive end expiratory pressure ablates this effect. When you recruit this socked-in, degassed lung that's crushed under its own superimposed pressure, if you increase its volume with PEEP, you actually homogenize the stress raisers, and you increase the lower lung volume, which then flattens the diaphragm and mitigates some of that contractile effort of the diaphragm and ablates the ability of the diaphragm to generate that low pleural pressure. So it's these three things really coming together. So I'm calling this the conjoined triangle of distress of P-SILI. And they all kind of, as I mentioned, tie into each other, that if you have high stress raisers, so severe disease, there's a nice voxel analysis on CT scans done by Cresoni's and colleagues that showed that the more stress raiser burden you had on a CT scan, very simply, the lower your P to F ratio, so the more severe disease, less than 150, less than 100, you have almost by definition high stress raiser burden. It's also related to your dead space fraction, so the higher the PaCO2, you can infer the greater the stress raisers. So you can also see it on a CT scan, lung ultrasound. So when you've got this lung that has this ability to augment radial traction forces, you're going to be at risk for volumetrauma and barotrauma. And when you have these high stress raisers and severe disease, typically that triggers the lung to engage in greater effort. You're more hypercapnic, you're more hypoxemic, you have a collapsed lung that triggers increased effort. And as mentioned, that increased effort lowers the pleural pressure around the stress raisers, augmenting the risk of volumetrauma and barotrauma around the stress raisers. And that effort, coupled with low PEEP, so again, PEEP homogenizes stress raisers. So if you've got low end expiratory lung volume, the lung volume is collapsed, that augments the ability for these disparate changes in pleural pressure to augment the radial traction forces. The low PEEP situation, all of these three things co-conspire to increase the risk of P-SILI. And I think this also kind of speaks to how to treat it. So a good way to get rid of stress raisers is to use a high PEEP strategy. Prone position also homogenizes the lungs, gets rid of those dependent stress raisers. Increased effort, so you've got to monitor for that. It's hard to do. Most papers talk about using esophageal manometry. Nobody really does that. It's mostly going to be a clinical exam. Diaphragm ultrasound might be a future avenue to study effort. Patients that are intubated, you could look at something called the P0.1, which normally should be less than 2 centimeters of water. If it's greater than 3 or 4, it suggests it's high effort, but largely this is a clinical gestalt, and it suggests that treatment with neuromuscular blockers could be beneficial. But I think that's tempered by whether or not you're using a low PEEP or a high PEEP strategy. So if you've got low PEEP and lots of effort, you're going to be at risk. And I think this helps explain some of the disparate results between, the first big neuromuscular blockade trial that was published in 2010 that was beneficial. Those patients had severe disease, high stress raisers, but they were treated with a low PEEP strategy, compared to the Rose trial, which was more recent, had high burden of stress raisers, had their effort blocked with neuromuscular blockers, but both groups received the high PEEP strategy. So the high PEEP strategy may have washed away the stress raisers, may have washed away the patient's ability to generate negative effort, and may have normalized the groups and neutralized any potential benefit from blocking effort. The low PEEP also raises concerns about patients with high stress raiser burden who are treated with high flow nasal cannula or non-invasive ventilation that's not a helmet, let's say, where there could be leaks and less PEEP. So in patients like that, they could be at higher risk for self-inflicted lung injury. Thanks.